All right, everybody, it's 8:01. Time for me to begin. So I hope everybody was warm and safe inside and that your animals and the people in your life and your buildings have all survived intact. So with that, today for Grand Rounds, we are very honored to have Dr. Donita Croft presenting Grand Rounds today, and she is a clinical assistant professor in the Division of Allergy, Pulmonary, and Critical Care Medicine here at University of Wisconsin. And she's going to be talking about her area of expertise and interest, and the title of her talk is Survive But Not Recover, Chronic Critical Illness. So a little background on Dr. Croft. So she reminded me we were in medical school together, which, of course, I have all blacked out of my mind and had no idea. So she went to medical school here at University of Wisconsin. She did her residency at University of Iowa in Iowa City in internal medicine, which she followed by her fellowship in pulmonary critical care medicine also at Iowa. During that time, she got her MS in epidemiology, and she did some very interesting postgraduate work. She was at the Epidemic Intelligence Service for the CDC. And in fact, after she finished that, she did work for the CDC. She was an active duty lieutenant commissioner for the United States Public Health Service. She has been in the inactive reserve as lieutenant governor for the United States Public Health Service as well. And she told me that she was actually there during 9/11 and did some of the work on anthrax at that time. She's been an instructor here with us at University of Wisconsin in allergy, pulmonary, and critical care since 2002. And she joined on faculty as a clinical assistant professor in 2007. In her area of expertise, which is chronic critical illness, she does hold some leadership positions. She is the medical director at Select Specialty Hospital. And with that, Dr. Croft, would you please come on up and talk to us about Survive But Not Recover, Chronic Critical Illness?
Thanks so much, Betsy. I agree that medical school was kind of a black hole. Seems like a very long time ago. I appreciate you all braving the end of the polar vortex and the vortex of school and clinic closures to come today. I do appreciate that. So today I'm going to talk about Survive But Not Recover, Chronic Critical Illness. The only disclosure I have as in my position here, I am the medical director of Select Specialty Hospital here in Madison. The learning objectives are to recall 4 clinical characteristics of chronic critical illness, understand the prognosis of illness requiring prolonged mechanical ventilation, and identify a poor prognostic indicator of prolonged mechanical ventilation, and appropriately identify patients for referral to a long-term acute care hospital. I'm going to talk about the clinical characteristics of chronic critical illness, venues of care for chronic critical illness, the scope of the problem, outcomes, and palliative care considerations for chronic critical illness. So over the last few decades, there have been improvements made in acute critical illness recovery. There's been decreased early deaths from sepsis, which goes along with early sepsis identification and rapid evidence-based care. There's been reduced mortality in trauma patients due to trauma protocol and trauma care centers. Unfortunately, along with this improvement in acute critical illness recovery, there has been creation of a new subpopulation of patients who survive the acute critical illness, but go on to have significant sequelae from the illness, the chronic critically ill. An unintended consequence of the life and death focus of critical care medicine is the growing number of patients who survive a critical illness, but are left with significant impairments of function and quality of life and markedly shortened lifespan, the chronically critically ill. This was a term that was first used in the 1980s to describe an emerging group of patients who survive but do not recover from acute critical illness and go on to have multiple organ failure. So there is a progression into chronic critical illness. Typically, patients start out with chronic comorbidities and then have an acute critical illness and then spiral down into chronic critical illness. Some of the types of illnesses that instigate this spiral down are pneumonia, acute respiratory distress syndrome, sepsis, other infections, cerebrovascular accidents, trauma, heart failure, coronary artery disease, and surgical abdomen. So the proposed pathophysiology, unfortunately this is not very well understood. There's been some research on this area, but not a lot of research. The proposed pathophysiology is that the initial adaptive responses of the sympathetic nervous system, the endocrine system, and immune system persist. These are usually, they support survival in the first 24 to 72 hours of an acute critical illness. However, when recovery is not achieved, patients go on to have rampant inflammatory response and organ dysfunction. The physiologic transition from acute to chronic critical illness typically occurs around 5 to 14 days post the onset of the acute critical illness. So this is a schematic drawing of the proposed pathophysiology of chronic critical illness, and it shows a trajectory of 3 different clinical pathways. So you start out with an insult, such as sepsis, and have basically a cascade of pro-inflammatory markers, and then some patients, there's a systemic inflammatory response that occurs, and some patients have multiple organ failure fulminant at that time and have early death. Another population of patients kind of have homeostasis in the immune system and the infection and go on to have rapid recovery early in the critical illness. However, there is this middle pathway that occurs, and the hallmarks are organ dysfunction with persistent organ injury, persistent inflammation, immunosuppression, and catabolism. And much of this kind of seems to cycle on itself and cause worse and worse illness. And patients go on to have profound disabilities and, unfortunately, indolent death frequently. The clinical features of chronic critical illness are many. The hallmark is respiratory failure. So there is prolonged mechanical ventilation that is required because of the respiratory failure. Unfortunately, there's not an absolute diagnosis or a definition, that's used for prolonged mechanical ventilation, but the proposed standardized definition is 21 consecutive days of at least 6 hours of ventilatory support, mechanical ventilatory support. There are many other definitions that are used, and especially in the surgical literature, it tends to be much shorter periods of time that are called prolonged mechanical ventilation. Some of the post-cardiac surgery literature even uses 24 hours as the cutoff for prolonged mechanical ventilation. And all of these other definitions make it difficult to compare the literature and risk stratify. The respiratory system, one of the things that makes pulmonary medicine so interesting to me is that it is affected by so many other body systems. So it's affected by nutritional status, by muscle weakness, cardiac ischemia, really all the body functions can affect respiratory function and can cause and contribute to respiratory failure. Really, the respiratory failure with chronic critical illness is an imbalance from an increased respiratory load and decreased respiratory muscle performance. Another commonly affected area in clinical characteristic of chronic critical illness is the central nervous system and neuromuscular dysfunction. It can cause delirium, coma, polyneuropathy, polymyopathy, all can contribute to chronic critical illness. This author actually called chronic critical illness a perfect storm for infections. And that's because the patient population tends to be immunosuppressed, they have long hospital stays, frequently multiple antibiotic courses throughout their long hospitalization, and have nosocomial causes for infections with frequent drains, lines, and tubes. Cardiovascular system can be affected by chronic critical illness and can contribute to chronic critical illness with heart failure, arrhythmias, and ischemia. Endocrinopathy is a problem with anterior pituitary hormone abnormalities, hypothyroidism, decreased prolactin levels, decreased growth hormones, increased cortisol levels, hyperglycemia, bone loss. And unfortunately, malnutrition can occur even basically despite adequate nutritional replacement with protein catabolism, low albumin levels, anasarca, decreased micronutrient levels, especially iron, selenium, zinc, and vitamins A, C, and E. Certainly, there are a lot of symptoms that go along with chronic critical illness. Difficulty communicating, pain, shortness of breath, thirst, also isolation from family and friends. So this definitely contributes also to the chronic critical illness. So where are patients with chronic critical illness cared for? Certainly they typically start out in an acute intensive care unit, and they could stay in an acute intensive care unit. The advantages of that are in the intensive care unit, they're able to care for unstable patients, and all possible interventions that are needed are available. The disadvantage is the expense and limited availability. Certainly, we get high census notices very frequently that the ICUs are full, so availability is really a limiting factor. And typically, the focus of an ICU is on acute critical illness and not so much on chronic critical illness. This is the American College of Chest Physicians put out discharge criteria for when patients can leave or should leave ICUs and go to a lower level of care. This was from 1998. It's not been revised since then, but I think that it still is applicable today. Basically, they suggest that patients be medically stable, that non-respiratory organ dysfunction is stabilized, sepsis, hemodynamically they're stable, the sepsis is controlled, that they don't have uncontrolled hemorrhage. There should be a treatment plan in place for all conditions, and there should be adequate nutrition program in place. For respiratory stability, they need to have a secure airway, either a tracheostomy tube or a stable regimen of non-invasive ventilation, be able to clear secretions, have stable airway resistance and lung compliance, have stable oxygenation, and stable ventilatory settings, and no need for sophisticated modes of ventilation. So another option for where a patient with chronic critical illness could be cared for is a ventilator-certified skilled nursing facility. The advantage of this is that it's lower costs, and it's sometimes closer to patients' homes and families. The disadvantage is that there are no daily physician rounding. There are few interventions available. If a patient is to go to a skilled nursing facility, their condition must be stable, and the staffing ratio is not advantageous for patients with chronic critical illness. So kind of the Goldilocks just right area for patients with chronic critical illness seems to be long-term acute care hospitals. They are lower cost than an ICU. They're daily physician rounding and coverage. Many interventions are available, and they focus on chronic critical illness. The disadvantages are that not all interventions and consultants are available at long-term acute care hospitals, otherwise known as LTACHS, and frequently they are far away from patients' families. So LTACHs are kind of a concept that is not necessarily well understood by the general population or by physicians. I'm just going to review a little bit more about what LTACHs are. They were created in the 1980s to facilitate transfer of medically complex patients out of intensive care units. They were created to decrease Medicare spending on intensive care level care and initially were intended for patients weaning from mechanical ventilation, although over the years they've evolved to also care for other medically complex patients. They are focused on patients requiring stays longer than the Centers for Medicare and Medicaid prescribed DRGs. So LTACHs actually get a separate DRG from the short-term acute care hospitals, basically hospitals like UW. And to kind of make sure that it's the right level of complexity of patients who are going to long-term acute care hospitals, Medicare mandates that there's an average length of stay of 25 days or greater for Medicare patients who are at long-term acute care hospitals. The typical target range is 18 to 35 days. So basically Medicare doesn't want patients, they don't want to be paying for a DRG at a short-term acute care hospital and then have a patient go to a long-term acute care hospital and just be there for like 3 or 4 days because they're paying a separate DRG for the long-term acute care hospital. The Medicare regulations have changed over time to kind of help with that balance of making sure that the patients who are there are kind of the appropriate level of care. Effective October of 2015, there were changes in the Medicare regulations, and now in order for full reimbursement, they have admission criteria that the patients have to have had a 3-day or more stay in an intensive care unit or critical care billing at the referring hospital, or that they have at least 96 hours of mechanical ventilation at the LTACH after they're transferred there. So the number of LTACHs in the United States has increased dramatically since 1991. In 1991, there were 91 LTACHs in the United States. By 2011, there were 436 LTACHs in the United States. And along with that expansion in the number of LTACHs in the United States, the Medicare spending that went towards the care of this population dramatically increased also. So that's another reason why the changes in the regulations to ensure that the right level of complexity of patient is being cared for at the LTACH. The distribution of LTACHs throughout the United States is not even. There tends to be many more LTACHs in the east and southeast, and in 2009, by state data, Texas had the most LTACHs per capita. They had 74 LTACHs, and that was one for every 334,000 people. Louisiana had the most per capita, and that was one for every 113,000 people, of 39 LTACHs, as opposed to California, which had, the most populated state in the country, had one for every 1.9 million people. Wisconsin then, as it now, has 5 LTACHs, and that was one for every 1.1 million people. So definitely the distribution is skewed towards the east and southeast, and much less in the LTACHs in the west. So this is a map of the distribution of LTACHs. It didn't actually say exactly what year it was, but it was at least 2003 and before 2006. So I think it was about 2005 that this map is from, and it shows the distribution is heavily skewed to the east and southeast. So this is a map of where the long-term acute care hospitals are in Wisconsin. There is one in Madison, and the rest of them are all in southeastern Wisconsin, the other 4. So the local LTACH opened in 2006. It is a part of Select Medical Corporation, Select Specialty Hospital Madison. Select Medical Corporation is a for-profit, publicly traded company out of Pennsylvania, runs 96 LTACHs in the United States. And I am not here to promote Select Specialty Hospital, but it's the local LTACH that we have available to us here, and it's the one I'm most familiar with because I've worked there for 12 years. So this is a picture. This was the minus 22 degree day a couple of days ago. There's somebody actually kind of running into the hospital there. So this is a picture of it. It's at 801 Braxton Place. It's across Park Street from Unity Point Meritor, and it's across Braxton Place from 1 South Park. It's a 58-bed freestanding facility. Approximately 25% of the LTACHs run by Select Specialty Hospital are freestanding. 75% are hospitals within hospitals, so they've rented like a wing or a floor within another hospital. Select Specialty Hospital Madison has a mean annual admissions of 477 patients, and that was between 2011 and 2018. There are 2 inpatient services there. There's no outpatient services that are provided at Select Specialty Hospital Madison. The 2 inpatient services, the Pulmonary Critical Care Service is a UW Health run service. The UW Health is contracted out to provide pulmonologists and intensivists there. And there's also a hospitalist group that's run by a private Michigan group. There are many on-site consultative services available at Select Specialty Hospital. Nephrology, infectious diseases, physical medicine and rehab are ones that we consult most frequently, I would say. Palliative care is also available. We have a Grace Palliative Care Services come there with limited psychiatry available through them. There are also a lot of consultative services that are not available at Select Specialty Hospital Madison. Anesthesiology, otolaryngology, which can be an issue when you're caring for patients with tracheostomy tubes. Many of the surgical subspecialties are not available at Select Specialty Hospital. General surgery is available there, and health psychology is not available at Select Specialty Hospital. Those are the ones that kind of come to mind that we kind of wish we had more of. So where do the patients come from when they go to Select Specialty Hospital Madison? So between 2017 and 2018, there were 818 admissions those 2 years. 46% of the patients came from UW Hospital. About 75%, about 3/4, came from hospitals within Madison in general. Unity Point Health and Meritor and UW Health combined is about 63%. And about 1/4 of the patients come from hospitals outside of Madison. Mostly in Wisconsin, but a handful from outside of the state also. The most common diagnosis-related groups for patients at Select Specialty Hospital Madison last year, it's very heavy on respiratory diagnoses and infections. So respiratory diagnosis with mechanical ventilation more than 96 hours or less than 96 hours, pulmonary edema and respiratory failure, osteomyelitis, post-op or post-surgical, post-op or post-trauma infections with major complications or comorbidities are some of those DRGs that are at Select Specialty Hospitals to kind of give you an idea of what patients we're caring for there. When patients leave Select Specialty Hospital Madison, they go to a variety of different places. The biggest plurality is to skilled nursing facilities. That's 40%. 26% of the patients go to their home, to their private home. 12% come back to a short-term acute care hospital. That includes patients who had planned readmissions, things for like post-op procedures, to come back for other procedures, cranioplasties and procedures like that. So that's both the planned and unplanned transfers back to short-term acute care hospitals. There are 11% who die at Select Specialty Hospital. 6% go to inpatient rehab, and 6% are in the other category. That includes inpatient hospice, people who leave AMA. There are a handful of patients who come from the Department of Corrections and go back to the Department of Corrections. So that's where people are discharged to from Select Specialty Hospital. In chronic critical illness, the treatment is basically supportive because there's not a lot of understanding what the pathophysiology is of chronic critical illness, so it's hard to have therapies that are directed towards that when it's not well understood. So supportive care is really the basis of treatment at LTACHS. The goal is also to use organized standard approaches and protocols to anticipate and prevent complications, and to basically give more time for the patient to recover. Certainly, it takes a village to care for patients with chronic critical illness, and we use a multidisciplinary approach to care. Includes basically all disciplines: nursing, physicians, pharmacists, physical therapists, occupational therapists, dietitians, case managers, speech and language therapists, respiratory therapists all work together. And some of the programs that we have at Select Specialty Hospital Madison that are multidisciplinary are antibiotic stewardship, multidisciplinary rounds. We have delirium rounds to help discuss patients who are having significant problems with delirium, wound rounds, and the ventilator weaning is also from a multidisciplinary approach. So we do have weaning protocols, a weaning protocol at Select Specialty Hospital. It's ordered by the physician, but it's directed by respiratory therapy. And the goal is to have a stepwise approach at a measured pace while not placing fatiguing load on the respiratory muscles. And it's based on the American College of Chest Physicians evidence-based guidelines for weaning and discontinuing ventilatory support. So that's just one example of the multidisciplinary approach at Select Specialty Hospital Madison. So again, supportive care is kind of the basis of care. We do awakening trials and spontaneous breathing trials. We try to be very careful about choosing analgesia and sedation for ventilated patients, assess and try to prevent and manage delirium, have early mobilization and exercise, and to involve family as much as possible. This is all basically from acute critical illness, but it's been kind of extrapolated to be used also for chronic critical illness. So the scope of the problem, about 5 to 10% of patients hospitalized with acute critical illness go on to have a chronic critical illness. They use but even though it's kind of a small percentage of the patients with acute critical illness, it goes to use 20 to 40% of the ICU bed days and critical care resources. It requires expensive and extensive care with an estimated cost of $26 billion of hospital-related costs in 2009. So it is a really significant issue. What are the outcomes with chronic critical illness? In a multi-center study of 23 LTACHs, there was a total of 1,419 patients with prolonged mechanical ventilation over a 12-month period that were enrolled in the study. The mean age was 72 years, and the illnesses were 61% medical illness and 39% surgical illness, which I think is pretty representative of what we see at Select Specialty Hospital Madison. The discharge data from these 23 LTACHs, 54% went on to be weaned from mechanical ventilation, and a significant amount of those ended up having their tracheostomy tube decannulated, and also a significant amount did not end up having tracheostomy tube decannulation. But it was a 54% wean rate from mechanical ventilation. 21% went on to be ventilatory dependent, most of them full-time, some of them just part-time or nocturnally, and just a handful, they included BiPAP patients who were dependent on BiPAP within that ventilatory dependent group also. And 25% died during the hospitalization for their chronic critical illness. In a long-term survival meta-analysis for prolonged mechanical ventilation, the group looked at studies that were published between 1988 and 2013, and they used the definition for prolonged mechanical ventilation to be either at least 14 days of mechanical ventilation or an admission to a ventilatory weaning facility or requiring a tracheostomy tube for acute respiratory failure. They included 124 studies from 16 countries. About 50% of them were from the United States of the studies. When they looked at the pooled mortality for during the hospitalization, 26% died during the hospitalization. The pooled one-year mortality was 58%, so quite high, and that was from 39 of the studies that included one-year mortality data. So a one-year mortality of 58%. The number of patients, or the percentage of patients who were discharged home was 22%, and the percent liberated from ventilation was 57%. So really, it's a very significant problem for patients who have chronic critical illness. It's a high morbidity and mortality. So just to kind of reiterate, the chronic critical illness one-year survival in this group of patients was 42%. And I'm going to apologize to the oncologists out there, but I'm going to use cancer as kind of a gold standard illness that patients dread and fear. And I wanted to compare the one-year mortality of 42%, the one-year survival rate of 42% with the common cancers that occur in the United States. I had a very nice librarian from Ebling Library trying to help me find the one-year mortality rates for cancers. And really, unless you look at the Kaplan-Meier curves, it's not published in one-year mortality because the mortality is better for most malignancies than it is for chronic critical illness. So they're published in either 5-year survival or 10-year survival. But when you look at the most common cancers in the United States, really lung cancer is the only one that has a 5-year mortality that is kind of comparable probably to what the one-year mortality is for chronic critical illness. And so, I certainly don't mean to diminish people's concern about cancer or diminish the wonderful advances that have been made in cancer care. But like the general population hears cancer and they think that is bad. But the general population hears about somebody being on a ventilator for 21 days and they don't really recognize that actually is not a benign problem either. So really, the one-year survival, again, 42% in that meta-analysis for chronic critical illness. So I talked about the mortality from chronic critical illness. So what is the other morbidity with chronic critical illness? This was a prospective cohort study done at Mount Sinai in New York, and it enrolled 203 patients and looked at they had a mean age of 72 years, and they basically wanted to look at what the rate of coma and delirium was in these patients after their illness. So 75% of the patients who were enrolled in the study came from their home when they were hospitalized for this illness. After this illness, only 7% of them went back to their home. So 75% came from their home and were living, probably relatively functionally, and afterwards only 7% were able to go back to their home. They had a 48% wean rate during their hospitalization. So they looked at their cognitive function, and 18% had some impairment at the time of admission, kind of pre-admission. And they were, at discharge, about 50% were comatose or delirious at the time of discharge. And when they looked at patients 6 months later, actually even more were delirious or comatose 6 months later at 71%. So it really can affect the cognitive function significantly. So another study of the functional status of patients who've had chronic critical illness. This was a prospective cohort study done in the 5 ICUs at Duke University. They enrolled 126 patients with prolonged mechanical ventilation, and they included patients who had been ventilated for at least 7 days, who had who they thought were going to need to be ventilated for at least another 72 hours. So not quite 21 days, but I think they wanted to get them early in the prolonged mechanical ventilation stage, so they were at 7 days. They enrolled 126 patients with prolonged mechanical ventilation, their surrogates, and their physicians. And they interviewed them at the time of the acute illness and 3 months and 12 months later for functional status. So this schema here, basically the darker the color, the worse the outcome. So white is alive with no functional dependence. The kind of very light blue is alive with some functional dependency. The darker blue is alive with complete functional dependency, and the darkest of the blue were the patients who died. Of the 28 patients, they found at 3 months that there was a 71% survival. So this is the 3-month data. So you can see that very few of the patients were alive with no functional dependencies. So of the survivors, 52% had complete functional dependence at 3 months. This is the 1-year survival, and that was 56%. 67% of those had been readmitted at least one time to the hospital during that 1 year, and 40% were completely functionally dependent. One of the things I found interesting was none of the patients who were completely functionally dependent at 3 months went on to be alive with no functional dependencies at 12 months. They all had some functional dependency. And even the people who were functionally independent at 3 months were not all functionally independent at 12 months. So it definitely affects patients significantly. 9% of the original cohort at 1 year were functionally independent. So just these little kind of slivers of white here were functionally independent at 1 year when they had a chronic critical illness. So it has very high morbidity, very high mortality. So looking at this group, how do we kind of figure out who's going to possibly do better and who is not going to do as well? So there have been quite a few studies that have looked at the prognostic indicators, and the two that really come up in all of the studies are older age and renal failure, either chronic renal failure or acute kidney injury as being poor prognostic indicators for chronic critical illness. Other ones that also have been shown to have poor prognosis, but not in as many of the studies, people with malignancies, thrombocytopenia, people who required vasopressors during their acute critical illness, patients who failed mechanical ventilation, liberation, people with low albumin levels, and basically the higher number of comorbidities, the more likely you were to be to have a poor prognosis. So good prognostic indicators, one of them was having a degenerative neurologic disease, which you don't get to say very often, that having a degenerative neurologic disease is a good prognostic indicator. But I think patients with problems like ALS can actually live fairly long on ventilators as opposed to kind of the other group of chronic critical illness. And in many of the studies, patients with degenerative neurologic disease were actually excluded from the studies because they seem to have kind of a different prognosis than the rest of the group. Having a cerebrovascular accident or having a chronic critical illness because of trauma were good prognostic indicators. So given the high morbidity and high mortality with chronic critical illness, what are some of the palliative care considerations that go along with chronic critical illness? So again, there's a lot of symptom distress and suffering that goes on with chronic critical illness. Patients very frequently tell us that the worst thing about the chronic critical illness was the difficulty communicating. And one of the things that we have tried working on at Select Specialty Hospital Madison is using a speaking valve early on in the illness. And in this study, there were no worsening in respiratory functions or other problems, and actually using a speaking valve in line with the mechanical ventilator showed improvement in quality of life with being able to speak earlier. It really is a big concern, understandably, with patients to be able to communicate with their family and their caregivers. So in the cohort from Mount Sinai, they looked at end-of-life care and looked at how many had healthcare power of attorneys at the beginning of the hospitalization, and only 21% had a healthcare power of attorney at the beginning of their hospitalization. 35% had do not resuscitate status. 19% eventually limited aggressive care, but it was at a median of 39 days after hospital admission, so it was a small percentage, and it was very late in the hospitalization. This was a very interesting study that was the same group of 126 patients out of Duke that I mentioned, the 5 ICUs in Duke that I mentioned earlier. They had talked to the patients, the surrogates, and their physicians at the beginning of at the day 7 of their hospitalization, day 7 of their mechanical ventilation, and asked the surrogates and their physicians what they thought the 1-year survival would be and what they thought the 1-year functional independence would be. And as you can see, there's a significant difference in what the surrogates thought the 1-year survival would be and what the physicians thought the 1-year survival would be. Also, the same with the functional independence. There was a significant difference between what the surrogates and the physicians thought would happen. So these were the actual data, what actually happened. 56% survived the illness and 9% were functionally independent at 1 year. So you can see that this has much more concordance between the actual data and what the physicians thought than what the actual data and what the patient or the surrogates thought. So there is definitely a chasm. There's a divide in what physicians think will happen, what will actually happen, and what the patients or the surrogates think will happen. So this was end-of-life information that surrogates remembered being told about. 26% of the surrogates reported that physicians discussed likely survival, general health, and caregiving needs with them. 20% of the surrogates reported receiving information about expected functional status at discharge, and 7% of the surrogates reported receiving information about 1-year survival. This is a study of the effect of palliative care-led meetings for families. It was a multi-center randomized trial. It was 4 different centers randomized trial. Patients had been mechanically ventilated for at least 7 days during this study, and they were approached and randomized either to the intervention group, which had 2 family meetings that were led by palliative care providers. That was 130 patients or and more of their surrogates, or the control group, which was given a chronic critical illness brochure and routine family-led meetings by the ICU team that was caring for them. That was 126 patients and more of their surrogates. And they followed up on these patients and their surrogates at 3 months. So at 3 months, the depression and anxiety symptoms there was no significant difference between their depression and anxiety symptoms between the intervention group and the control group. And actually, PTSD symptoms were higher in the intervention group than in the control group, kind of just barely at a significant level at 0.0495. So there were also no clinical outcomes differences. So in this group of patients anyway, having palliative care-led meetings actually led to some increased PTSD symptoms. So it may be that it's better to integrate palliative care provider discussions in with the primary team and have the primary team be involved in that also. And there may be factors that in this clinical population that make palliative care discussions more challenging. Certainly, I think there's a lot of optimism bias in this population, and I think that can really affect those discussions. So these are my observations. factors that are involved in chronic critical illness patients or families deciding to limit aggressive care. It takes a sudden worsening of the clinical status, or 4 or more family meetings over time discussing prognosis for patients and their families to limit aggressive care, or an impending transfer to a lower level of care that is not easily accessible to the patient's families. So because there is a 25-day average length of stay at a long-term acute care hospitals, I mean, they are not skilled nursing facilities. They're not places for patients to live. If patients are continuing to have improvements in their ventilatory weaning, many times they'll stay at the long-term acute care hospital more than the 25 days. But if there's kind of a plateau in their weaning and they're not progressing towards weaning, then we have to talk about transfer to a lower level of care from the long-term acute care hospitals. So there are 6 ventilator-certified skilled nursing facilities in the state of Wisconsin. They have 11 to 36 beds per facility. Only one of those 6 facilities also provides hemodialysis, and most do not accept patients with nasogastric feeding tubes, although that can be looked at on a case-by-case basis with some of the ventilator-certified skilled nursing facilities in Wisconsin. So basically, obviously, kind of the more complicated the patient it is, their problems are, the harder it is to get them into a ventilator-certified skilled nursing facility. And this is a map that shows where the ventilator-certified skilled nursing facilities are in Wisconsin. So there are none in Madison. There are none in the whole kind of southwestern part of the state. So when patients have to leave the long-term acute care hospitals that are in this area of the state and go to the skilled nursing facilities that are further out and further away from their families, that affects patients and their families' ability or interest in looking at de-escalating care. So occasionally we send patients home from Select Specialty Hospital Madison on mechanical ventilation. When we do that, it is because of kind of strong patient or family preferences to do that, or kind of paradoxically, sometimes the patients are almost too ill to go to a skilled nursing facility, so paradoxically, the only place for them to go is to go home, which seems very counterintuitive. So sometimes we basically end up setting up a mini ICU in their home to have them go home on mechanical ventilation. Which brings about the question, who cares for patients after they are discharged from the long-term acute care hospital? You don't really hear about outpatient intensivists. That's not what most people who go into intensive care medicine kind of think of in their minds, of having outpatient clinics for their critically ill patients. So it is really a challenge to find providers to care for patients when they are discharged from the LTACH sometimes. So some of the opportunities that we have, I think, for the future, certainly more research on pathophysiology of chronic critical illness so that treatments can be aimed at the pathophysiology of the chronic critical illness and not just supportive care. Having standardized definitions for chronic critical illness and prolonged mechanical ventilation would be very helpful to help risk stratify and compare patient populations. Kind of on a more local level, certainly we have opportunities to meet with families early and often. The TLC has, in the last, I don't even know, maybe 2 or 3, 4 years, has started having kind of more standardized family meetings with patients who look like they're going to be ventilated for 3 days or more. And I think that has really been helpful on our end when we receive the patients, that those family meetings have already been started. And certainly we want to continue with those and have those early and often at the long-term acute care hospital. I think also having the caveat in the back of our mind also that discussing this with families may cause them to have more PTSD. So of course it has to be done carefully. Advanced care planning for outpatients. I have become extremely vigilant about making sure that my outpatients have healthcare power of attorneys, and I think I guess I would hope that would be something that we could all strive for. A shout out to our social work colleagues at UW. It actually can be very easy to have patients be referred to social work for advanced care planning. They have 3 monthly classes offered at different UW Health locations. Those are the ways that you can contact, or a patient can contact them about getting into one of these classes. There's drop-in assistance for healthcare power of attorneys and advanced directives that is done every second Wednesday of the month on the first floor H elevator lobby down by the cafeteria. I actually signed mine down there about 2 years ago, so that's definitely very helpful. And you can also do a patient resource consultation, and you can enter either ACP for advanced care planning, patient resource, or social work in HealthLink for a consult to send that off for patients. So I want to acknowledge the people who helped to make this possible and would entertain any questions.
Thank you very much. This is a critically important area and one that many of us don't understand what happens with our patients. So questions in the back.
So the question was, how does hemodialysis affect outcomes, and is it something that I recommend? Do I recommend patients going on hemodialysis? Right. I think it's a very complicated question. It's a very good question, and I think the whole pathophysiology is not well understood, but I think that the renal pathophysiology and end organ damage has something to do with the cycle of perpetuating the chronic critical illness. And do I recommend it? I think that's on a case-by-case basis. I think that, I guess my personal opinion is that society has the mindset that all modalities will be offered, and so frequently trying to balance that can be very difficult.
Yes. Right,
that's a great question. So the question was about caregiver burnout, and are there any resources available for patients going through that process? Certainly, palliative care consults and getting palliative care involved, I think, is very important. Even though that study showed that there might be more PTSD, I think that's more a function of the patient population than it is the palliative care consultants themselves. So certainly we try to work collaboratively with palliative care to have more support for patients and their families. One of the things we're trying to work on more at Select Specialty Hospital Madison is more chaplain involvement. Right now it's fairly lean there for that, but that's a huge problem. I think that caregiver burnout and kind of how to handle that is still in evolution.
Any other questions? In the back.
Thank you very much for the talk. These patients who are on the ventilation, I'm assuming, have no opportunity to get off it. And I'm wondering, are the families of patients counseled to take the kind of ventilation?
So the question was basically the patients who go home on mechanical ventilation seem to have very limited options, and are they counseled on that before they go home? And I think the answer to that is we definitely struggle with that significantly. And you know, what I would find a reasonable existence obviously is very different from what other people
do, and we have those discussions kind of very frequently. What's the best case scenario here? What's the worst case scenario here? So we definitely have multiple discussions with patients before they go home on a ventilator, because it is a very limited existence after that. When patients go to skilled nursing facilities on a ventilator, they can and do continue to try to wean patients off of mechanical ventilation. That, of course, does not happen at home. They go home, it kind of stays where it is, or it gets worse. So that is definitely a struggle. I talk to patients about, if it looks like it's going to be days to a week or so to get off a ventilator, you stay at a short-term acute care hospital. If it looks like it's going to be weeks to about a month that you're going to be on a ventilator, you come to a long-term acute care hospital. If it looks like it's going to be months to a year, or you might not get off the ventilator, then the option there is the ventilator-certified skilled nursing facility. There are not a lot of good options at that point for patients. Many patients do choose to do a terminal ventilator wean at that point, but some don't.
One more question?
So the question is, do I have any thoughts about the regional disparity and the distribution of the LTACHs? The companies that run most of the long-term acute care hospitals are East Coast companies. They're out of Pennsylvania and Kentucky. So I think that's part of it. You're right, it does not go with the population of the country necessarily. And certainly Louisiana is not a heavily populated country or state, but it definitely has a lot of LTACHs. So I think it's reimbursement and where the companies are located.
Thank you.
Thank you very much.